Everybody? Good. So since we tried to project the ventilator screen here so that it's easier. So I just wanted to show you a couple of slides, but we can just check them out here in the sense of we tested a few hybrid ventilators. And by hybrid, I mean ventilators that are capable of doing both conventional and high frequency. The ones we tested was the VN500, the Fabian, which is also a Swedish, if I don't recall wrongly. It's a German person who actually built this thing in Sweden, an ex-Draeger guy, which is also a hybrid. And the SLE 5000, which is an English ventilator, and it's also hybrid. And basically what we wanted to test out was the relationship that each of them had with amplitude and the parameter that we talked about yesterday, which is kind of a new parameter when you shift from the sensor medics to these type of ventilators, which is what we call VTHF, or tidal volume in high frequency. So what really happens here, as everybody knows, there is an indirect relationship between frequency in high frequency ventilation and VTHF. And that means that when we start increasing the frequency, the oscillation gets a little bit shallower. Why? Because the area under the curve in frequency in the flow curve is smaller than if we have so if we increase the frequency, we will have a smaller area under the curve and therefore a smaller shift in volume, basically. And therefore, since this parameter relates very efficiently and very well with CO2, then the more you increase the frequency, the lower you will have VTHF and vice versa. So that is why when you decrease the frequency in a high-frequency ventilator, what happens is that you actually improve ventilation because you move from this to this, where you have more volume being actually oscillated. If we start seeing what happens with the relationship between amplitude or delta pressure and VTHF, then we will see a direct relationship in, for example, the sensor medics, until there's a threshold, evidently. There's a moment where this doesn't keep going up. But in these type of ventilators, and particularly in this one, you will see something like this. And you reach a plateau where even if you increase the amplitude above a certain point, you won't get any more VTHF, increase in VTHF. So you've kind of maxed out the ventilator for that particular frequency. So your choices are to lower your frequency, take advantage of this relationship if you want to actually increase your VTHF. So we're going to try and see that in practice and the relationships that you have between all the parameters in these type of ventilators. So let's turn out. One of the things that I wanted to show you and we talked about yesterday is that what we usually do as a protocol before setting up the VN500 independently, whether it's for high frequency or conventional, is we calibrate the screen. And why do we do that? Because after a while, tactile screens can get, offset a little bit, and you start touching things, and they don't actually respond. And that can be very annoying in a critical patient, and it's happened to me. So, and this we didn't learn with Draeger. Actually was taught this by one of the engineers that created this in Lübeck. And he said, obviously you can do this. And I said, nobody knows this, actually. And it's fairly easy. You just have to, what you do is you just press the wheel and this alarm silence button for 30 seconds. And then the screen will show if you want to calibrate. And what you have to do is you have to calibrate both position and strength. So in this one, it's a new version, so you just have to calibrate twice. And then it will respond, because once you start the ventilator, if you want to calibrate, you have to take the patient off ventilation to do that. And that's not very useful. Anyway, so let's so what we generally do and recommend is to actually have in your screen, it's very quiet. That's the first thing that stands out, because when you're used to the Sensormedics, which is quite noisy actually, this is amazingly quiet. We were talking about that before. So in closed rooms, like you have bigger spaces. We have individual rooms, but they're much smaller than yours. So they act really like resonant boxes when you put a Sensormedics inside. So it's not very nice. So this is one suggestion, and I saw that you already have it set up, at least in this ventilator, is that when you're using high frequency, it's very important in this type of ventilator to actually have, okay, this is what you're setting, okay? But it's very important to have these parameters on the screen, because this is what it's actually happening with the ventilator right here. Because you can set 15, but this is not the same parameter. This is what is actually being measured and reached at this point, okay? And that's very important, because when you max out the ventilator, the only way you can actually tell you're at this point is because if you keep increasing your amplitude, this number can increase, but this one won't. It will reach a point where you increase the number here, you dial more amplitude, but nothing happens truly with the patient. And remember, we had a very good and well-trained person that was moonlighting in our unit, and she didn't actually know this ventilator so well. And things happen, and the nurse that was in charge of that patient was also a new person, so two things went together, and she spent all night trying to improve increasing the amplitude, and things were just not happening. And she was kind of applying the recipe of Sensormedics with this ventilator, which was the one that she knew how to ventilate high frequency with, and it just didn't work. And that's what usually happens. So I'm going to show you a couple of things. So let's start with, I think if you were to ventilate a newborn, a very premature newborn, let's say a 700-gram baby, you would probably choose a higher frequency, right? So you're probably used to frequencies above 12 or 13, even 15 for a very small baby. And the reason, does anybody know the reason for small babies, high frequencies, big babies, low frequencies? Is there any reason for that?
I don't think there's any study data.
But there's a physical explanation to that is that you have what's called the resonant frequency. So bigger bodies tend to resonate with lower frequencies, and smaller bodies tend to have this resonance frequency and oscillate better with higher frequencies. Having said that, the problem is that with this particular ventilator, I will show you that it's not so efficient at higher frequencies. So let's just dial it as if we were doing that with a sensormedics and see what happens. So let's dial in 15 and IE ratio, which is the typical, the one you would see as 0.3 in a sensormedics. I think with the protocol that you're about to start, you're not allowed to play with this. We do, and I'll show you why, with the bigger babies, but you're only going to ventilate premature babies. And, okay, so we can choose a mean airway pressure, and let's say the baby was on 8. So you're supposed to go like a high volume strategy, a couple of centimeters above that. So let's put 10. And what amplitude would you choose in a sensormedics to start with? Theoretically, it's a gamble in practice, because you're going to eyeball how much approximately until you see the baby oscillate well. And that, as you well know, is very dependent on what surface the baby is and what type of lung the baby has, if it's a very sick lung. And usually when we connect a baby to high frequency, particularly to a sensormedics, is because the baby is not doing very well. So here we have dialed 15, and we're actually getting 15. So let's start increasing that, assuming that we're not getting the PCO2 that we want. So the first strategy, if we would have a higher PCO2, probably everybody would accept to increase the amplitude, right? So let's just do it kind of abruptly and go to 20 and see what happens. It does reach 20, okay? So we're still dialing something and getting that. And if you see, we're getting also a change in high frequency tidal volume. And this DCO2, it's what's called the ventilation coefficient. And it's just a formula that the ventilator uses, and all high frequency ventilators that have a flow sensor actually, and it's depending, it's very correlated with PCO2, and it's dependent on VTHF squared times frequency, respiratory rate in hertz. So that means that if you want to increase DCO2 and you increase amplitude, let's go back to 15. So you will see that we will automatically should have an impact on this going lower, and eventually this going lower. So more or less it's 1 times 1, obviously 1 times the frequency, it's more or less 15. So it's something that the ventilator is calculating. And we'll get to that later, because some people we tend to use more this parameter, other people tend to use this one. The problem with using this one is that when you're in the volume guarantee mode in high frequency, things get a little bit more complex with that parameter, and I'll show you why. So let's try to go back, and we already tried 20. So 20 means that we are actually getting 20. We're increasing our tidal volume high frequency, our VTHF here, and that's always impacting the DCO2. Let's assume that we need more ventilation, and we go to 25. I'm scaling up relatively quickly, and we're already seeing something there. And we're beginning to see that we're dialing here something, but we're not able to reach the desired amplitude as dialed. And this is telling us that we're getting to this point where if our strategy is going to be keep increasing amplitude for lowering PCO2, it's simply not going to have any clinical effect. And I can assure you of that, because we can dial whatever we want here, but nothing's really happening. And that's because the ventilator is maxed out. And this ventilator has much less power at higher frequencies than the sensormatics. So,
Is that because your diaphragm is so much smaller?
yes. We can once we turn it off, I can show you the diaphragm, because it has a mixed mechanism. It's a flow interrupter, but also it's an oscillator, a tiny oscillator. You've seen the respiratory valve. We can disassemble it later. It's very easy. And so we'll pump it up to 30 and see what happens. Nothing whatsoever. So this is what happened to our new doctor in the unit. She was in a very reasonable amplitude, but she was not getting any results. Why? Because although she was dialing this here, nothing was happening there. And this is interesting, because that's why it's so important to have on the screen the true amplitude. Otherwise, you won't know that this is actually happening, and you'll feel very comfortable with what's going on here.
Why does it max out though?
Because the diaphragm can,
Maxed out as much as it
it can't give you any more. But look what happens now. If I lower the frequency, let's go to 12. It will automatically have the same problem, but at a higher set point. Now again, we have our limit much higher. And that's why the protocol that you're going to begin soon starts with 10 hertz. Because if you would start a baby on 15 hertz, you would run into this problem pretty quickly. And so it really, because what's really important is what's going on here. Because this is the parameter that's going to really correlate with your ventilation, and not necessarily this one. Because if I change the compliance there with the same amplitude, I will have a different VTHF. And we can do that by excluding one lung and reducing the compliance to 50% of what it was originally. So if I do that, so we modify the compliance, and now we will probably start seeing some effect if we go a little bit down there. Probably at this frequency I won't see that effect so clearly. But let's try to increase and see what the upper limit here is. Let's go to 35. So now we maxed out, but at 31. So again, no matter what I dial here, and what we generally do with the piglet is we test each of these steps with blood gas. And you can actually see the correlation that you don't improve CO2 until you've actually increased that parameter. Otherwise, it really doesn't make any difference. So again, we're at 40, let's go back to 35. And if we now take the frequency to 10, it has a different limit. So at okay, so at 15 hertz, we ran out almost at 21, 23, at 12 hertz, at 30, and here we have a bigger, much higher threshold before if we go to 40, it will still be able to, depending on the characteristics, but now we're again maxing out. So I read the protocol. There's not so many details, but I suggest that you always look at this and compare, because if you were with a patient right now and your strategy would be to increase a little bit, we generally never go above 40. I don't know what your protocols here are, but we try not to go above 40 because it usually is very close to the limit of that frequency. And so, at least in our system, our approach here would be to lower the frequency. Otherwise, you won't do anything. Nothing will happen eventually. Yes?
On the oscillator, there's sort of an informal rule that you try to stay less than 3 times your mean airway pressure, because it's felt that the mean airway pressure is being artificially propped up with amplitude. And you can demonstrate this by pausing the oscillator, and you'll see your mean airway pressure drop. So normally, if you have an appropriate relationship between amplitude and mean airway pressure, if you pause the oscillator, the mean airway pressure should stay exactly the same. But if you pause it and then the mean airway pressure drops by 2 or 3, that means that the amplitude is propping up that mean airway pressure, and it's considered to be out of an abnormal relationship of one to the other. And so what you try to do is, what you just mentioned, increase your mean, come down on your amplitude. Do you sort of employ a similar strategy with the Draker?
Yeah. In general, we try never to go this far.
So what we have right now is kind of it's not really an appropriate relationship of amplitude to mean with 40 and 10.
Probably not. Yeah, I think it's a little bit.
In the real world, you might have more mean and less amplitude.
Yeah, definitely. So, but what doesn't happen with this is because the expiratory phase is not so active as it is with the sensormatics, you don't run the risk of going into negative pressures in the airway, which is a risk that you have with the sensormatics, because since it has a huge diaphragm, you can actually, in the negative phase, you can potentially have, with going here, exactly. So you can have, if this is your mean, you can potentially, with very high amplitudes, because it's so efficient, you could potentially have,
and that's where you get
little peaks below or negative, truly negative.
You'll collapse your airway.
And you could potentially have that problem. And that's a problem that with this type of ventilation, it's less likely. The same as with the jet ventilation, because the jet ventilation in some ways is very similar to this, because you have the high peaks, but you don't have the negative peaks. So, so we tend to have at least an approach in relation to, and we tend to start with 1 to 1.5 mLs per kilo for a baby as a starting point. But I can show you some data. Manuel Sanchez Luna from Spain actually has some data published. I don't remember the journal, I have it in my computer, but that even in an animal model, in experimental conditions, the 1.5 mLs per kilo of VTHF, 2 and 2.5, have an enormous variability from one animal to the next. So what we tend to do is that we correlate the VTHF to that particular patient in that particular moment. So once we arrive to a VTHF, and I understand the protocol you're about to begin, that's what it suggests, to a VTHF which correlates with a PCO2 that we feel comfortable with, then we can switch to a different mode, which means saying, okay, now I want to hold on that VTHF and let the ventilator handle the amplitude. And that's called volume guarantee in high frequency. So it's a completely different mode to what we used to, and it has some drawbacks, but it has something that's very interesting. And look at the following. If I start to obstruct the ET tube, what will happen is that the VTHF will quickly fall. So if you have any secretions whatsoever, it will quickly show you, whereas, as you all know, the sensor medics, you can clamp the tube and nothing happens. And this, for our nursing staff, is a sign, okay, something's happening, right? Because the system is working perfectly. If we were in a sensor medics, the sound of the machine, no alarms, everything goes well until the baby starts desatting. But that's a step further. So we can anticipate with this system. The thing is that what I miss with this ventilator is that I wish it had a VTHF alarm, but it doesn't. So the way around that, how we use it, is we go into the volume guarantee mode. So what it will alarm, it will say, okay, we're not arriving to the correct or to the VTHF that you're asking me to hold on. So that's interesting, and it kind of gives you the idea when you start looking at this parameter. It's like when we switched from ventilators without screen and we weren't looking at tidal volume, and now everybody uses tidal volume for conventional ventilation. So now we can actually see, okay, if we were moving 10 ml and suddenly we start moving 5 ml, something's going wrong, right? Probably the tube has gone too far in and we're only ventilating one lung. So that definitely is a sign and a new parameter, at least if you're coming from the sensor medics. So let's, yes?
What is the range of this? So we're not in our system going to touch the frequency. We're going to keep it at 10, but you said you do alter it. So how low do you go, and what's the maximum VTHF that you can accomplish? So do you go to 8 or 5? Or
Generally, we don't go above 3.5 per kilo, but it will depend. And there isn't a strict, I mean, there is a relationship between these two parameters, but it's dependent on the lung, the airway, the baby in particular. So what for this baby reaches this amount, for another baby it might be completely different. So it's patient.
The hertz, when you adjust the hertz, what is the lowest that you
As far as 6. We have gone to 6 sometimes, but mostly in bigger babies. But we've also done, mostly with premature infants, we begin at 10. Some people begin a little bit higher, 11, never above 12, because of the reason I just showed. And we can go as low as 8 sometimes. But I understand the protocol allows some, so you're allowed to go a little bit down with the frequency. Once you've,
Important that the starting point is 10, which is really the biggest clinical shift for us.
which is coming down like 5 hertz,
Yeah.
just like this. Yes, and that's, but I think it's very clear when you see what's really happening. And what I find interesting with this type of ventilator, and it's changed completely our way of ventilating, is the fact that we're changing, we're seeing more. Why? Because basically, as I said yesterday, we have a midpoint that we didn't have before, which is we know that what's happening in the machine gets attenuated more and more as we arrive to the patient. So we begin with this amplitude here, but we have an attenuation as we arrive to the alveoli. So normally, the sensormedics is not only efficient because of its huge diaphragm, but because of its very low compliance circuit, and it's quite straight. So it loses almost no power from the diaphragm to, so this attenuation curve is like this. So it really is very long. Whereas here, we have a midpoint. And that midpoint is the flow sensor here. So it sounds logical to think that if we start getting a lower oscillation in that midpoint, that should correlate with less oscillation in the baby. And that's what we're starting to see. We have kind of, we are using this parameter as a correlation with CO2. And that's why it makes sense, but it still needs to be proved. There's very little data. There is a correlation between VTHF and PCO2, but it's patient dependent. So in one patient, that might be 3.5 per kilo. In another patient, it might be 1.5 per kilo. So it's very variable. Okay? So just want to show you, I know you're not allowed to change the IE ratio, but I want to show you one thing. We're maxed out here, so if I pump it up to 45,
Everybody close your eyes.
and we've dialed in 45, and we have 37 here. So we're definitely maxed out. What happens if I go to 1 to 3?
You have to fill out a lot of paperwork.
Yes. That's what happens, yeah, sure. But I just want to show you the relationship. There is a relationship between IE ratio and VTHF. When you make it even 1 to 3, and that would be in a sensormedics 0.25, which I don't think you can dial in a sensormedics. you will lower the delta P and, by definition, lower the VTHF. What happens if we go to 1:1? Before, we were maxed out at 37, and now we kind of boost the ventilator, and we go to 45, exactly what we've dialed. That's why we ventilate term babies with 1:1, because we have more power. And you hear the ventilator working differently. You can even, and it's actually performing better.
You don't have trouble with air trapping?
No.
So it's still, okay, so exhalation though is still active, or it's partly passive, or?
It's not as the, I mean, I don't know if, here it was not allowed to be used, but for a while we used the Babylog 8000 as an oscillator, because it does have an oscillator module. And with that one, it's just a flow interrupter. So I wouldn't do this with a flow interrupter. But this one, since it's a little bit more active aspiration, we don't see any air trapping. But we reserve this, and what we've seen, because at first in our, lots of people were using this and were saying, okay, this as the same as the other ventilator, it doesn't ventilate anything above 2 kilos. It does, in fact. We've ventilated 3.5, 4 kilo babies with, very full of edema, no problem. But you just have to ventilate differently.
Right.
That's the whole thing. Okay.
Anyone ever tried a low compliance circuit, like a Tygon tubing circuit? Has anyone ever tried?
We tend to use, not this circuit, a different circuit. I'm not sure this is the circuit you're going to use for the, this is the one. This seems to be more, because we generally use the Fisher and Paykel, the disposable circuit, and what we see is that although it's a more compliant circuit, for premature babies, they do just fine. But we use a different type, but I think this is Draeger, right? Oh, this is, so it's a different type because it's not colored, it's just plain white on the inspiratory and expiratory, but I guess it's almost the same. We reserve this for bigger babies where we need more power, because obviously this attenuates part of the oscillation. But I think you won't have that problem because you'll use this one during the whole protocol.
That tubing that if you took an oscillator circuit apart and you used that heavy clear plastic tubing that comes with the oscillator, it'd be interesting to see how much more you could get out of it.
More power, probably yes. Yes, probably yes. So that was just a parenthesis. No paperwork to fill. Let's go back to 1 and 2. And what happens once you arrive to the point that you say, okay, the baby is on the right. So we're having 35. So we're getting on the adequate VTHF. We have the PCO2 that we wanted. So now what we're going to tell the ventilator is, okay, let's go to volume guarantee. So we dial the same as in conventional volume guarantee. We dial the volume that we want, and we say, okay, let's stick to 2.2. But I'm going to give you a credit of amplitude to play with. That's going to be 40. And you have to use this the same as you would the maximum inspiratory pressure in regular volume guarantee, which is the amount of pressure that the ventilator will eventually use if required to reach that tidal volume. So now you lose control over amplitude, and what happens is you eventually go to, and this appears, VG, and then what's happening here is that this is no longer determining what's happening here, but you lose control over amplitude. What you're dialing in here is the maximum amplitude. So the ventilator took over the regulation of amplitude. And now what is the objective is 2.2. So if the tube starts getting obstructed, and forget I'm doing this, I just want to give more power just transiently. Just let's make believe that was 1 to 2. But just for the demonstration purposes, I'm going to obstruct the tube a little bit. So what I'm trying to do is to show how the ventilator is responding, increasing the amplitude to arrive to the desired VTHF. Because what we dialed in is 2.2. So now it's adjusting the amplitude on its own to arrive. So it's very important if it doesn't arrive, so that's important to limit the maximum amplitude to a reasonable amount. Otherwise, what could happen is that you're giving a lot of credit that the ventilator can use without asking. What I am saying is that, for example, if this gets more obstructed and it's max out, then it should alarm and say, okay, I'm not arriving to the desired VTHF. So troubleshooting there should be, is the tube obstructed? Are we having some water in the system? Anything that has reduced the efficiency of the oscillation. So that's an important alarm, and we are using more and more this as a strategy to actually know when the baby is full of secretions and we have to actually suction them or whatever. Okay, so we're having 1.6, and one has to be careful because if you don't realize that you're on volume guarantee when you connect a baby, and one of the problems of this ventilator is if you switch it off, sometimes it remembers the last parameters, and then you connect a new baby, and it's happened to us. And both the nurse and the doctor did not realize that the volume guarantee was on. The baby was having a very high PCO2, and the physician did what she should have done, increase the amplitude. So she went and increased the amplitude. But what happens here? Nothing. Why? Because what you're increasing is not the actual amplitude, but the maximum amplitude that the ventilator will reach. So she got to a point, she said, okay, this is not working. The PCO2 keeps in 75. So the next thing she did was lower the frequency. If you're maxed out with amplitude, okay, let's see how it performs. Look what happens. Initially, a boost there. But the ventilator, what it does, it compensates lowering the amplitude. Why? Because it goes from one pattern to the other. So now the objective of the ventilator is to actually keep the VTHF constant. So it will dial down the delta P. And the baby was kept very constant during the whole night with a PCO2 of 70. So when I arrived in the morning and we were rounding, I said, it was really strange. I said, something's not right. And I went to the ventilator and I saw this little VG and I said, come here. Did anybody realize this baby was on volume guarantee? Oops. And that was because we were introducing this modality and not everybody was on board. So it's kind of dangerous to start using something new when not everybody's very familiar with.
Can you talk about the practical side of moving patients and doing skin-to-skin care, which is supposed to be a benefit of this? Are you seeing that you have to make changes, or it does a very good job of maintaining constant with
Okay.
traditional movements?
Generally in high frequency, we don't do skin-to-skin care, but I can tell you about what the theory of, in theory, what would happen, because those are our most critical patients. I don't know if, because with the sensormedics, you just simply can't.
Right.
It's impossible. But what should happen is that you're changing the baby from one surface to another. The problem would be if, you know, the mother is cuddling the baby, and that could attenuate the vibration. So the ventilator could get to a point, if it's in volume guarantee, where increasing the amplitude just doesn't do it. And it will probably alarm to a point where it says, I'm not reaching the desired VTHF. That's what I would expect to happen anyway. But we have no experience in skin-to-skin care with high-frequency ventilated patients, not with this system. Okay.
Well, you're changing the compliance of your external, so yeah.
You can skin to skin on this board.
You're praying, but yeah.
You can lay like this.
You can lay, but you cannot grab.
No one is
So I think even if you're in volume guarantee, I think you have to be always monitoring what's going on with this number. Because if this number starts going up, it probably means the baby or something is going wrong. Because if the baby, the lungs get more stiff, the compliance gets worse, it will be more difficult to oscillate, and the ventilator, if we've dialed this, will pump up the delta P, the amplitude, and to try to arrive to this, and it will compensate, obviously, to a certain point. But this, at least for us, is a very good parameter, also if the baby is getting better. Because if compliance is increasing, it's improving, this number tends to go automatically down. So the same as in volume guarantee in conventional ventilation, it has kind of a way of weaning the baby to a point where it lowers the delta P or the amplitude to a moment where you say probably we could do well with conventional ventilator, or I don't know if, I don't think, are you allowed in the protocol to extubate from high frequency? Okay.
Extubate. We'll extubate the bubble CPAP because that's what we use here, and so we want to stick to our standard care. But do you all extubate from the oscillator to
Sometimes,
sometimes?
not always.
Depends on the
Most
baby.
times we try to switch to conventional. But the advantage, you're going to use the ventilator, but you're going to use it only as high frequency, so you're still going to have to shift from one ventilator to the other. For us, using this ventilator has a huge advantage. You don't de-recruit the lung when you're trying out a patient in high frequency. And you're not troubling the nurses either, because I mean, for us it's a For us, it's a huge thing. You know, if you ask someone to bring the sensormatics, to actually set it up, to do a trial out, and after half an hour you say, it didn't work. That's not well taken, usually, at least not in our unit. So with this, you run the risk, no problems, because you just try out, and then if it doesn't work, you just dial back conventional ventilation. So
I know Sarah
it
is
works.
much more helpful than that, yeah.
But I think you won't have that chance because
We don't, I mean, Sarah
you have to
said
go
that-
back to.
'cause I've asked in like 3 different ways, trying to trick her into saying, yeah, you can do that. But she catches me every time. She's like, the answer's still no. So they tried with the FDA to do that, you know, these are full Draegers, and it's just a matter of switching the button. They said absolutely not. So the IND is only for those with the oscillator mode.
Right.
She said she'll catch us if we try it, because everything's recorded.
Yeah, it is.
So what happens, you have your baby on this setting, and now the baby's getting more edematous and your CO2's going up. What increments do you usually change your volume guarantee?
What you can change are 2 parameters. If you remember the diagram we saw yesterday, if you want to increase ventilation or CO2 removal, what you will try to increase is VTHF. So, because now you can dial VTHF. You can say, okay, now instead of 2.2, I can have a 10% increment and go to 2.5, for example. So I would increase to 2. And then we will have an increase, and that should have an impact on CO2. If you want oxygenation, obviously, as usual, you would increase mean airway pressure or FiO2. So in a way, with this type, because usually the problem in high frequency is not to, oxygenation gets simpler from the theoretical standpoint in the sense that you have FiO2 and mean airway pressure. Both are knobs in the ventilator. So those are the 2 parameters you can actually dial. With the PCO2 in conventional, you have frequency or you increase your tidal volume. Here, when you're in volume guarantee, that is finally reaching a higher VTHF, whichever way you want to do it. If you're on high frequency and volume guarantee, you just dial a higher VTHF. If you're on conventional high frequency, then you either increase amplitude to reach a higher VTHF or decrease frequency. And that, as we saw, will increase VTHF. So that would be our approach.
So you said 10%, is that like a typical bump, or is it dependent on how high?
10%, maybe. I don't think we do more than 20% changes. And if I recall right, that's about what's suggested in the protocol. Yeah, we never go above 20%. I think, although it's not as efficient as the sensormatics in removing CO2, it is very efficient, as all high-frequency ventilators. And we're always more scared of low PCO2s than high PCO2s. So yes, we don't dial up more than.
Do you use transcutaneous monitoring?
Yes, we've had some problems with some equipment lately, but we try to use that a lot. Yeah, we use, generally a baby that's on high frequency is generally with NIRS and transcutaneous CO2 and saturation, obviously.
So what is, like, in your mindset, I'm just trying to shift because, in conventional 4 to 6, and as you get closer to 4, okay, we're ready for extubation. So is there a tidal volume or VTHF on here that you're, when you get to that, like if you get down to 1, you're like, okay, now we get a conventional how are you saying, okay, I'm ready to wean off high frequency with these settings?
I don't recall the exact number you might have it in mind, but obviously if you're down to 1.5 per kilo or less, probably you could do very well in conventional ventilation. And there are some specific criteria for your protocol to actually plan the extubation. But what we do generally is when we start seeing that the VTHF is an
Delta P that weans itself though? Like,
yes.
don't you just keep, wouldn't the volume stay constant unless your PCO2 is too low?
What will happen here is it will wean this parameter
Right.
automatically. This is in volume guarantee. If you are getting
But you get your blood gas next morning, and if it's low, then what you're gonna wean is the VTH.
exactly,
Okay, so you're
exactly.
saying
Like, when you're practically using it, not for a protocol, when are you saying, okay, I've gotten the benefit of high frequency?
When we are below 20 here and we're beginning to wean this and we're on our low 40s in PCO2s, we start dialing down the VTHF until a point where you can either extubate the baby directly or change to conventional, whatever the attending physician prefers. But generally, that is becoming more and more a parameter for us if we regulate that per kilo. And let me see, I think the new version of the software actually lets you, no, this doesn't, it's blocked. But the new version of the software allows you to dial in the settings when you're admitting a patient, the weight of the patient, and in conventional ventilator, it will report in the tidal volume per kilo according to the weight that you made the input with, and it will also report the VTHF per kilo. And most people say, okay, below 1.5, probably you're not needing high frequency anymore.
And do you have a coefficient, like you say, okay, I'm at 1.5, I multiply by 3 and get where my conventional volume would be, but that hasn't been worked out.
The problem with the coefficient is, look at this. If we tend to, if I put up the frequency, what will happen here? Normally these two go together. But since the ventilator is now fixing this parameter, if we change the frequency, it will modify, you see? It will modify that without changing this, because now the system is working differently. We're not altering the amplitude to impact these two parameters, but what we're doing is we're modifying, we're fixing one of them, and if we change the frequency, this will change, but this will remain fixed. Okay? So at least in volume guarantee, this is not so well correlated as is this with PCO2. If you're off volume guarantee, then yes, you can use either of them. And I think the protocol warns you about that when you're modifying anything here, you could have changes in DCO2 and no changes, obviously, because you're on volume guarantee in VTHF.
Can you speak to also, we actually during the protocol, you can wean them out.
Okay.
When you're weaning, you don't want to forget about that. That's also a variable and easy.
Okay.
You don't stay at 10.
No. You're talking about the mean airway pressure. Yes, but I think that's in relation to the oxygenation, obviously. And that doesn't change. I think that's no different from what you're doing. Yeah, you're no different than what you're currently doing with the sensormedics. I think the big difference with the sensormedics is not in the oxygenation part of it, but in the ventilation part of it. I think that's where this, at least in my opinion, this ventilator actually shines, because it's more efficient in many ways. Or not more efficient, but it tells you more about what's happening really in the patient. When we go back to the sensormedics, we feel a little bit lost because we know what we're dialing, and sometimes we do in bigger patients, but we don't know what's actually happening with the baby, because we kind of miss these parameters. It's like if you went to conventional and you weren't allowed to know what the tidal volume was, you'd feel a little bit off. The same happens to us when we're not able to see this anymore.
But it's, I want to make sure maybe that's a parameter that they can monitor.
Oh yes,
Because
definitely,
actually,
definitely,
they've enrolled 2 patients.
definitely.
One of
This
them,
is weanable, absolutely, yes,
we,
yes,
were able
yes.
to come off and still had it.
Yeah, yeah, definitely. Okay, any other questions? I think we're right on the hour.
Thank you, that was awesome.
I hope it was useful.
So good.
Absolutely.